Conference will now be recorded.
Oh.
Okay, well, I'm in class.
Hey, do it. I want to see. Oh, where's she at?
There you go.
Sure what?
Oh, girl, I'm only coming to talk to you. Oh, you single in there, CJ?
Yeah. You have to drive home.
Weird. Yes. Okay. Every night.
What time do you usually get home?
9:19, I got home. No.
Oh, yeah. That was fun.
So far, the roads are just wet.
Yeah, that's fine. Okay,
Immigrants.
back
only part
to
that.
regular business.
A little full of breath, though.
Okay, so respiratory rate greater than 25, pulse ox less than 94, retractions or accessory muscle use, any two of those three things, they meet criteria. And then if they have any of these things, the exclusion, they don't get put on it, right? We
Yeah,
don't,
but-
just any one of the exclusions, yeah. Mhm. Yep,
It's not even fair. 4 ounces is a dose.
that's the whole thing.
No, that's like the little time to go in. Right?
Okay, I'm
Sorry, I interrupted you. Yeah.
No, you're good. I just want to see you drink the thing, really.
I've had it.
Did you puke?
But boy, second in, it was tough.
Pooping everything out.
Just something dangerous.
Okay, so we're gonna assess this poor patient, all right? I'm gonna try and mute it. All the doctor is asking is, how many times have you been intubated? This guy's labs. And, I'll pull some names. And we'll see
Good
what
stuff,
y'all
that's
see.
you.
And you let me know, it's not going, you let me know if you would put this patient on CPAP. So,
Oh, it's in the Bronx, CPAP,
Bronx,
definitely.
okay. Oh, and he's online. I'm gonna try and call people that are. Hurry on.
Yes,
Yeah,
yes.
okay. Two are like the same name to me, Marissa and
And
Mariana.
Mariana.
They're the same. Okay, what do you see? Okay, what alludes you to that? Good, so he's tripod sitting, all right. Billy, what else do you see?
He was like really using his inner muscles.
He's using everything, right? Okay, Harlan.
He has a mask on.
That's awesome.
But no, you can see his eyes too.
Yeah.
They're bulging out a little bit.
Yeah, he looks scared.
He's struggling.
He looks scared and he's struggling, right? So see how we don't have to take his shirt off to know that he's using everything up here? You can see it pull up in his armpits even. He was getting tired.
Let's just keep giving him.
Okay, Allie, would you put him on CPAP or no?
Yeah, right now, yeah.
Good, we don't know his blood pressure, but just by looking at him, that should be the first thing that pops in your head is CPAP. So one important thing that he's like, have you ever had a mask put on your breathe? That's what he's talking about. So, all right, let's CPAP.
Is he getting albuterol right now too?
Yes.
Is that what that is?
Yes. Yeah, so that little fog that
Uh-huh.
you've seen, that's all albuterol. Maybe like a Duonet, that's just another medication, but yeah, albuterol. So this is our little nebulizer treatment. Yeah, it's a mask. We have ones that patients can hold, but this one specifically, we also have ones that just go on masks. If someone's struggling this bad, I'm not gonna make them sit there and hold it to their face.
They're having health issues. Yeah.
I've also, funny story about those, patients love to like, especially ones that have been smoking, they'll smoke it. Like they're smoking a cigarette, like you hand it to them and they'll be like, and then they'll talk to you and it's over here just like spilling all over the place. Like, that's not good. Okay, good. So one of the important things, that's pretty much it. We can watch it again so you guys can get into it.
He's fine.
One of the important things
He's
that the
in the
doctor
Bronx.
asks
He'll
is how many
survive.
times he's been intubated. So that's an important question to ask these chronic breathing problem patients, is how many times they've been intubated, because that clues you in on like how severe and how aggressive you need to be. They've been intubated a bunch of times, they've spent a bunch of time in the ICU, chances are that they're sick. So that's always a good question to ask. So we'll play it one more time just so y'all can take a look at everything.
One to four, probably, right? That means he's got pretty bad obstructive disease. Have you ever been intubated before? How many times? 4 times? He has having a severe asthma attack, and he's got a history of asthma. He's been put on a ventilator several times before, so he has the potential to get really sick really quickly. He's having trouble breathing right now. We're going to put him on a machine that's going to help him breathe and open up his lungs a little bit. Just hang in there. Somebody that you've been on a CPAP.
He's like, I've never been on a CPAP.
Okay. Is this one of your worst attacks that you've ever had, or you had worse? You had worse. All right, that's good. Then he was like, these guys is.
I think so.
Breathing, we have to put them on a ventilator. We have to sedate them and what's called intubate them, which is put a tube down that throat to help them breathe. And they get a lot of other problems associated with that. Infections from the tube. They lose their ability to breathe on their own. They have to go to the ICU for some.
So by definition, this guy has altered mental status because he's keeping his eyes closed until someone talks to him. That by definition is altered mental status. He's still putting him on a CPAP. So whenever you see the altered mental status, don't put someone on CPAP because altered mental status. That's why I say if they're able to follow commands. The easiest way to check to see if they can follow commands, just be like, hey buddy, give me a thumbs up. If they give you a thumbs up, they're following commands. And that comes in handy whenever they have the CPAP mask on and you're continuing to assess if they have like an ability to follow commands. Because if somebody has a mask on and you go to talk to them, all you're going to hear, you're not going to hear anything. So always like thumbs up, 2 thumbs up, something. Give them something to do. All right. So, Jessica. How do you know your ventilations are good? Providing positive pressure ventilation.
Watching the chest rise and fall.
Good. What else? I guess I can call them name. Jake.
He's like, "Dang it."
Hold on, where's my notes?
I'm about to stand over this way, so I'm having a hard time hearing you.
Okay. Where's my names? What are you gonna see with like their color? Like say someone's really cyanotic.
So they're blue and
Good.
certain colors.
Good. Frank, what other thing that you might see? So it kind of goes hand in hand, like you'll see their color improve. What else might happen with like up here? If their brain wasn't getting oxygen and now you're giving them good oxygen. Yeah. Yeah, sometimes patients, like especially kids, if they're like out of it because they're not breathing good and you start breathing for them, they'll start like waking up, looking at you, that kind of stuff. You'll see mental status improvements. Good. So, chest rise and fall, the rate's good. What's our rate? 1 breath, how many seconds when we're bagging? 5 to 6. 1 breath every 5 to 6 seconds. No resistance in bagging. So what they're talking about is like as you ventilate, you're not feeling this bag push against you. Right? So you'll have a lot of resistance. It'll be hard to squeeze the bag. You'll see their oxygen saturation go up, hopefully, and then skin color changes.
What causes the resistance? The incorrect bagging or?
It can be incorrect bagging. It can be the position of their airway. So sometimes you just need to readjust. Another thing that can cause it is like pneumothorax. So make sure you're like readjusting and then being like, hey, maybe there's pneumo, but let somebody know if you ever feel resistance so we can troubleshoot it. If you have like a tube, like like you're breathing through like an ET tube, and you're feeling resistance, it could be a sign that that got dislodged and is no longer in the right hole too. So it's always important to let whoever you're working with know that you feel resistance. Even if you are like the senior provider on the truck, just let everybody know so everybody's on the same page. Communication is good. So here's our pulse ox. What are we aiming for?
95 to 99.
Yep, 95 to 99. Another thing that I want to point out, I think it's on the next slide. Did everybody get everything written down? Okay. So our pulse ox pleth wave, Pleuth, pleth wave. So when you put somebody on a pulse ox, there's a chance that this little wave that comes up, or like this wave right here, see how that's nice and pretty and uniform? It's all the same. That's a good pleth wave. So sometimes you can put somebody on an SpO2 and they have thick nail polish, or their fingers are especially cold that day, or they're moving their hand around a lot, and you'll get a waveform that looks something like this, or like this, or like the noise artifact, and it'll give you this like crazy low number, like 72%. And everybody sees the 72 and they're like, oh crap, they're not breathing good. But check that waveform, because you want it to look nice and uniform, like the normal signal on the top there. So if you're not getting that normal signal, troubleshoot your pulse ox. Treat your patient, not your monitor. So if I'm sitting here talking to you and you put a pulse ox on my finger and it's crap, and I'm just talking to you, I'm like, yeah, I'm breathing fine. I don't know what's going on. Don't freak out. Now, if you walk in and they're blue, you're still going to treat the hypoxia. Don't wait for that number to pop up, right? So treat your patient. All right, so we're going to assess how they're breathing, the rate, rhythm, and quality. So are they breathing fast or slow? Are they breathing too shallow or too deep? And then are they like struggling to breathe? Are they sitting there talking to you breathing? Are they not breathing at all? Like, assess that respiration. Make sure you're talking with your patient, right? Like that guy was saying, like he was talking to that patient. He's like, hey, is this the worst one you've ever had? And the guy's like, no, like I've had breathing problems way worse than this. He's still talking to his patient, right? So even though sometimes it might be hard for them to breathe, sometimes they got to answer those questions so you know where your starting point is. If you're ventilating for the patient, like Chaz was saying, place the mask over their mouth and nose. If it's a CPAP kind of thing, kind of talk them through it. It's going to be stressful. It sucks. People hate it. And I don't blame them, because I also hate it. And then make sure you're timing your ventilations with the patient's respiration. And like Chaz was saying, if they're breathing really slow, breathe a little bit faster, but breathe with them on their respiration. So when you're ventilating a bradypnea, what does bradypnea mean? Slow breathing, good. So assess their respiration, explain the procedure to the patient. What if the patient's completely unconscious? Do I need to explain it to them?
Yes.
Yes, I do. That's my little spiel. We don't know what people can understand and what they can't. So I've had patients that completely unresponsive, unconscious. You might think that they might not know what's going on. That's not always the case. So just talk to your patients, even unresponsive patients. We had a good a patient of ours that went into cardiac arrest while she was in the hospital, and they got her back obviously because we were able to hear the story later. But she could hear, her heart had stopped. She could hear everything that was going on around her. And whenever they brought her back, she woke up 2 days later and was like, what happened? Like, I heard you guys running in and out of the room and yelling and doing all this stuff. And they're like, yeah, you died. Like, your heart was not beating. And she could hear it all. So make sure you're talking to your patients. Get a good mask seal. We talked about that in CPR class. So if you have small hands, you can do the technique where your thumb kind of digs in here and you pull up. Or if you have bigger hands, you can do the CE clamp. So I have bigger hands. That's just who I am. So that helps me. Just depends. And then add ventilation in between patient zone to increase the rate. The ramping position. We've all seen this. We all know it. We all love it. I was watching a video the other day, and they were talking about keeping your patient supine, and they called it the corpse position. And I love that, so I'm going to start using it. So we want to ramp our patients. It's not as easy for us to ramp them and do all our airway stuff, like bagging them or keeping them ramped, especially if they're big. But just know if you lay them supine, it's our corpse position, right? So we don't put them in a corpse position. So it's going to be an ear to sternal notch or ear to nipple line. That's what we're aiming for. We bring their head up, pad behind their shoulders, and keep their head a little bit back. That sniffing position, like you're smelling flowers.
Does that mean kind of like a burping thing? Whatever you're gonna.
So the burp maneuver is whenever we're intubating, we might tell you to give pressure on the trachea, and it's burp stands for backwards, upwards, rightwards pressure. So you kind of push in, and we can probably show you on our mannequin. So what it does for us is it takes those vocal cords that we were looking at. I don't know who all stayed behind our last class, but those vocal cords, if we can't get a good view of them and someone puts a little bit of pressure on that trachea, it brings those vocal cords like perfectly into view. It just kind of moves it back a little bit. So that's where it would differ, but we would put somebody in this position to intubate them, yeah. So some characteristics can make it hard to get a seal. Dentures, if they're out, they don't have that form on their face, it can be hard to get a seal. Another thing is the beards, those are hard. Don't go shaving somebody's beard because you can't get a good seal, please. Good luck finding a razor that's effectively going to like shave their beard. That's not a thing. We have razors, but they're not great. So I have 2-person techniques is great. With the beards, you can take Tegaderm, like this little plastic film stuff that every ambulance has. You can put it on. It might rip out a couple hairs, but it gives you a really good seal. So if it's like real bushy and real bad, you can kind of work around it a little bit.
They were saying in the book that you can let it down too.
Yeah. So lube, that's a perfect thing. If you like take lube and put it on the beard, it can also form a better seal. You're like, shh.
Like you just did that.
He's not even paid attention.
No, sorry, I was trying to find this video.
Which one?
The New York, Buffalo, New York guy that died.
Oh,
AMR.
Calvin has it in his slideshow. Oh, chapter 23. I can't remember what day it is. March 17th, maybe. Calvin's going to be teaching out. So I'm so excited. He
He's
showed
got
me
the AMR. Where they kicked the guy in the back of the
Yeah,
head.
it's I think so. You found it already? We can show it to them again. I mean, they can see it twice.
So, I want to take away Calvin's glory.
Okay. All right. Yeah, I'm excited for Calvin to come teach y'all. I will
Good
say,
luck.
I will say Calvin is very intelligent, as y'all can tell. He's got like that level of autism. So whenever he's asking you their scenarios in his PowerPoints, make sure you know those sheets. Like look over those sheets a few times before you start getting into Calvin's PowerPoints, because he's going to ask you scenario-based questions, and I love it. I think it's great for y'all. But just know he's very particular, and it's good. All right, BBMs. So Ambu bags, BBMs, whatever we call them, BBMs. I'm sure somebody calls them Ambu bags. Ambu is the manufacturer name, so they say Ambu on it. So we have adult ones, pediatric ones, and then infant ones. Because of the tidal volume that we give or don't give through one of these giant bags, we have used these like middle pediatric ones on patients or on like adult patients before, because you're still giving a normal tidal volume. Yes.
FedEx doesn't tell you outside.
Oh, they don't. It's all peds. Good.
A lot of services have swapped to that because it's cutting the volume in half. And so it's kind of preventing the cognitive offloading of like people over bagging and over ventilating their patients. So a lot of people will just take the adult mask and put it on the pediatric BBMs. It works.
Really good, because you're not having to think. Like in the moment, you're like, oh no, they're not moving. So you're like freaking out and bagging them. It happens to everybody. So it kind of takes that away, that human factor out of it. So. All right, so troubleshooting, we talked about this a little bit. So reposition the head, make sure you have a good airway opening maneuver. if you're doing one, like say you're doing the head tilt chin lift and you just can't get a good ventilation, try the jaw thrust or vice versa. So as long as there's no C-spine, go ahead and change. Check your mask. Some of these masks, they'll get an air leak around them. So like right in here. So like right in here, and you'll notice with like our training masks, some of them I've had to toss because they'll get like a hole right here. So they shouldn't do it on brand new ones, but things happen. So make sure you're checking for air leaks around. Make sure you're checking for any cracks or anything. Check the airway. So if you're having a hard time breathing all of a sudden, it was great, and then all of a sudden it's bad. Check for an obstruction. Check for an obstruction in your BVM. Vomit likes to get up in here. Blood, that kind of stuff. It can get up in here, so make sure, don't be like, because that's going to go in your face, but check that. And then resuction. And then always be mindful of a pneumo. Even if you're not dealing with a trauma patient and you're bagging somebody and all of a sudden you get resistance and you've done all these things, listen to lung sounds, because that pneumo can happen even if it's not a trauma patient.
That's the one where you go through the grid or whatever, right?
Yeah. So as the ALS will needle decompress or finger thoracotomy, depending on whatever your protocol is.
That's why inside the one.
Huh?
Pneumo's inside the one.
So pneumo is a problem like with the outside of the lung, or usually there's like a puncture in the lung, sometimes blebs. There's injury to the lung. So that air that's supposed to be going into the lung goes inside that space between your lung and your thorax, like your interstitial space, and it just pushes that lung down. So ventilation of a stoma. Stomas disgust me.
Yuck.
They are so gross to me. So mucus plugs are the biggest thing. So stomas, I think I have a picture on the next slide. They're a hole in the neck. And so usually the patient has had it placed for whatever reason. It could be like long-term ICU stuff. It could be long-term care stuff. I've had a guy that had a stoma in Atlanta. He went to take a drink at one of the clubs and they put acid in it. And so it burned everything. So he had to have a stoma. Like the reasons for somebody having a stoma is infinite. But biggest thing is mucus plugs. So those mucus plugs, they'll be trying to hack them up and they can't get them out. That mucus is like thick. It's like concrete. So you might have somebody, a partner, and I speak from experience, that takes saline, like in our little flushes, and puts it down the stoma to help loosen up that mucus. It works fantastic, but do not be standing in front of the patient whenever they do, please. I had a firefighter that was standing there, her hair's all down, she's watching, and the paramedic put saline in. I had never seen it before, so I'm like, what's going on? And the patient's like, and this thing shoots, and it sticks in her hair. And I was like, oh, I would have gone immediately home. Like, immediately cut my hair off, immediately gone home. Like, get out of the way, because those things, like, shoot. So, mucus plugs is a big thing, and they're thick, and they're yucky.
Has anybody watched The Pit? Anybody watched the new episodes of The Pit? No? All right. Just don't stand in front of people and they're freaking holes. Because things come out of them. Very aggressive manner.
Yeah, stand back. If you're gonna ventilate a patient through their stoma, use a baby BVM mask. You can also use like our eye gels. They're really small. The kiddo eye gels, the tips of them are like this big. You can put that over their little stoma and ventilate. Some of them have like a trach tube in there. And so you can just hook the BVM right up to the trach tube. So depending on the patient, stomas are scary because we don't see them very often, especially if someone's like at home on a ventilator. Those can get kind of scary too. So if you ever need to bag somebody, it is a possibility that their at-home ventilator stops working. So it's not abnormal to have to bag these patients. If you're trying to bag them and you're not like seeing any chest rise and fall, if you cover their mouth and nose and then try to ventilate them, because sometimes that air seeps up and out the mouth and nose. So just cover.
What if you covered the stove?
I've heard of people doing that and it working.
Just like
Yeah.
tape on it.
Duct tape on the pocket.
You don't need this.
Yeah, I've heard of that working. I've never personally done it. So yeah, that's what it looks like, the hole in the neck. So where that little plastic piece is, that's this little one-way TEP valve. So if that thing's malfunctioning or it's not even in there, that's why we cover the nose. And then you can see it goes down into their trachea. So anything that you would normally cough up through your mouth comes up through their little trach, and it's yuck. So you say yuck.
Yuck.
So little baby mask. This is a little LMA, but eye gel, same theory. So little baby eye gel fits right over that way. It's good. Here's what that tube looks like. So there's the actual tube that goes in their neck. If they're on a ventilator, they have one of these and it just plugs right in, but your BVM can hook right on the end of this. There's a little pilot balloon. So this balloon, if it's flat, it's telling you that this cuff, this balloon cuff right here is flat. So that's like the external way to look at, like, okay, that balloon's good. There's something called an arbitrator that works like it gets put in there, and that's to kind of help guide it in. The arbitrator comes out and the tube stays in. These things can get gunked up with those mucus plugs as well. Try not to remove them unless it's like clearly causing a big problem. Don't just go ripping them out. Be like, let me fix it for you. Because if that cup is inflated while you go to rip it out, it's going to cause a lot of trauma. I've had patients that have had these and they've been coughing and messing with it so much that it feels like they have a mucus plug. Like they told me, it feels like I have a mucus plug, but there was just so much swelling around it. So try not to like jostle it or try to rip it out or anything. And 98% of the time, if you go on a patient that has one of these placed in their own home and they're using it, they know way more about it than you ever will, or their family does. And so listen to them. If they're like, yeah, we tried this, 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 and this, and it's not working. And they told us that whenever we call EMS, that EMS needs to do this. I'm like, okay, I'm doing that then, because they know more about it than I ever will.
Any of these specialty devices, always refer back to the parents or person, because they are very well educated on these things. Don't feel like you have to know everything.
Yeah.
Listen to the people.
Yeah.
We do it every time.
Yeah. I have a lot of patients that are like, I'm on this weird drug. And I'm like, I don't know what that is, so I'm going to look it up, or they'll just tell me what it is. Because I'm human. I don't know everything. All right. The automatic transport ventilators. If you see one of these things, you can call it the 80s and let them know that you still have their medicine. I've never seen one of these on a truck. I'm sure that there are services out there that carry these. These things, time and time again, have proven to be horrible for patients. So if you look at the little knobs, there's a set breaths per minute. It tells you, you click it either child or adult, and then it tells you, or you can click which tidal volume you want to give that patient. So you set it, hook it up, and you let it go. And it just sits there and ventilates your patient. But there's no external mechanisms to let you know if the patient starts breathing on their own, if it's now getting resistance, like say your patient now has a pneumo because you accidentally hit 600 for a tidal volume and your patient only needed 300. And now you're like blowing up their lungs basically. So there's no external source to let you know like, hey, things are going south. You just set it and forget it. So if you see one of these things, make sure you follow your protocols. I don't recommend using them. I've always been told not to use them, even if I do have one on whatever service I work for. So, but that's what that is. Oxygen cylinders. I have another handout I'll give you guys on Thursday. So we carry the D cylinders. I always get these confused. We carry the D cylinders. So we have 350 liters of oxygen. There is a thing on top, regulator,
Yeah.
that tells us how much oxygen is left in the tank. So we always change them out at 500. So the PSI or whatever, we'll change it out at 500. But usually, if you have a national registry question, they will say like you have a D cylinder and you put a patient on a non-breather. How many minutes of oxygen does that patient have until like go on to your next oxygen. And usually it's 20 minutes, but I have a whole sheet handout that you guys can have and look at and read just to know. But the most common ones are these M. Those are like the ones that are on the truck. They're sealed in there. That's what we're hooked up to. And then we carry these around. Occasionally you'll see an E, like if someone's like pulling around an oxygen, that's usually an E tank, I believe. It would be a lot easier if they measured these in like bra sizes because everyone would remember. They'd be like, oh yeah, these are A's and these are triple B's. They don't do that. They don't do that. My brain's like, I don't remember. All right, cylinder safety. The tip of these oxygen cylinders, if they get broken off, they turn into a missile.
Oh, yeah.
So they should never be stored upright unless they are secured. Don't leave them stored upright unless they got them little straps on. Because if that thing falls over, I've seen videos of them going through like concrete walls. So don't be throwing your oxygen tank around. We use non-ferrous wrenches, so they are not going to cause any kind of spark because oxygen is very flammable. Right, so make sure that. Do you want to go grab an oxygen bottle? Okay. Thanks. Appreciate it. I know. That's why I was hesitant to ask. So, there's little O-rings that sit in these regulators. Make sure that they're in good condition. Sometimes they have one-time use ones. They're usually green or white. We use the reusable ones. They have like a rubber ring in them. Make sure that it's in good condition because rubber gets like old and will break and stuff. So without a good seal, if you're trying to put that regulator on an oxygen tank, you're going to hear it leak and then you're going to be like, why the heck's it leaking? That's probably why. We're always using medical grade oxygen. I don't know if anyone just carries around non-medical grade oxygen, but they wanted it in here. So whenever we open it up, we open the valve fully to blow any kind of air out of it before we put the regulator on. And then once we open it, like once the regulator's on, we'll open it halfway. Another thing is when you're cranking these things down onto an oxygen bottle, you use like this little T piece right here. And some people, it just needs to be like finger tight. It doesn't need to be like, I've seen people take like their shears, their trauma shears, and like grab it and crank it down. Don't do that because these little pieces, these little metal pieces will break right off and it's a pain in the ass for the next person. So it just needs to be finger tight. That's it. So we carry the big ones, have the little ones. Chaz is grabbing the other regulators. You might see different regulators. Some of them have like a little green pigtail that hangs off of them. That's for like vents can hook up to them. Certain CPAPs can hook up to them. Not our CPAPs because they just go right into, so like right in here. Let's see, this not right? No, it's not. This little thing is where your oxygen tubing hooks up to.
Okay.
Thanks.
Oxygen bottle. Tactical oxygen deployment for combative patients. So, like Becca said, these things can be dangerous. So try not to freaking dink the end of it off. So whenever you first get these, this is what they look like. They've got a little plastic. Sorry. This is what they look like. They have a little plastic cap that comes on them. Pop the little plastic cap off. This is the regulators that we carry. Some of these, like this one, doesn't have this hose on it, right? This is for our ventilator. So if we're moving a patient on a vent, we can hook them up to this. It has all your numbers on the side to go as high as this one goes up to 25. Some of them only go up to 15. So just keep that in mind. Oxygen goes in the bottom down here. And when you put this on, if you look on the side of this, I'll turn around. There's two little holes on this side right here, right? And then on the other side, there's only one hole. If you look at the inside of this regulator, there's two little hookups. and then on the other side, it's just the screw, right? So it's just the one. Like I was saying, this O-ring right here, just on the inside of this, right? If you go to put this on and you tighten it down and you turn it on and it's blowing air all over the place, first thing you want to check is that O-ring. Just make sure that O-ring's still there. But sometimes that comes out, goes bad, whatever. If you do happen to put this thing on wrong, this oxygen cylinder is empty, so it's not going to make a lot of noise. If you happen to put this thing on wrong, see if I can get it to make it. Can you turn this on? It's going to sound aggressive. It's fine. It's not going to hurt you. It's just going to make a bunch of noise. So whenever you put this on, some of these have like the little wrench thing that we use like this for, right? So we'll stick it on the top, crack it open. This one has a little turn knob. So you just crack it open, it'll go up. Like I said, we're looking for this thing to be out of the red above 500. If it's not, then we'll replace it. So that's oxygen. We'll go over it more on Saturday. We'll let you put the regulators on and off so you get like a feel of what that's like. And then just kind of tinker with it some. Oxygen.
Question about oxygen.
Oxygen. And whenever you use it for combative patients, typically I like grabbing it right here and like where you get the Yeah, I have drugs for that. I don't have to do that anymore.
Green hose. He says for the endotracheal.
No, so this is for our vent. It has a special hookup, so we can have somebody like on our vent. Not our automatic transport ventilator. It's not the same thing. We have a whole nother machine that'll breathe for the patient. But the oxygen, if you're gonna put it on, green goes to oxygen, and it just fits right on here. And then you turn it years per minute that you want. We'll let y'all play with it. All right. Hazards of oxygen therapy. Oxygen is flammable. So, this is burns from somebody trying to smoke a cigarette. How many times you show up and someone's like, yeah, I can't breathe. And they got their oxygen on, they're out on the front porch smoking. More times than I can count. Not every single cigarette's going to blow up their oxygen, but just know that it's a possibility. Oxygen just helps that fire burn, right? So it's going to burn worse. And then if the tank is punctured, we don't want it to become a missile. Here's a video. I'm not going to make you watch the whole thing, but it just shows you how oxygen can exacerbate cigarettes.
I'm Judy, I'm a Stevensburg Fire Marshal. I'm here with Shane Westfall, Portage County paramedic, and Ben Schultz. He's another.
A good oxygen level for a human being should be above 95, although it's very important that oxygen is used for many.
I'm Judy, I'm a Stevensburg Fire Marshal. I'm here with oxygen tubing that you would find in a healthcare setting in the U.S. And now this does not have any oxygen flowing through it. So what we'll show up a simple lighter is that the oxygen tubing will burn, but when the flame is removed, it self-extinguishes. So it's not a good combustible piece of plastic. The plastic will self-extinguish and go out. Now, what we'll show you with later on with that tubing, when oxygen is applied, the tubing will rapidly combust. And that's because we're increasing the oxygen in that tubing. So oxygen in normal air around us is about 21%. When we increase that oxygen percentage to 90 or 100%, it affects the chemistry of that material and aids in that combustibility. So we call that the fire triangle. To have a fire burn, we need to have three things: oxygen, heat, and fuel. So by taking that one side of the fire triangle and increasing at the oxygen side, we're making that fire oxidizer burn rapidly, much more than it would in normal air. So to demonstrate cigarette burning, we'll light this one and we'll introduce extra oxygen. So what I'll do is I'll get the cigarette burning and I'll use my mouth to blow extra oxygen at a normal rate through the cigarette. You may see more smoke, but the cigarette isn't going to change its burning characteristics. So as I blow through it, I'm normal amount, 21% actually less than it's been in my lungs through the cigarette. So try as I might, going as hard as I can, the cigarette does not change. And then we have that cigarette burning. As the oxygen flowing, you can see the cigarette rapidly oxidizes and combusts until the oxygen is removed. As soon as the oxygen is removed, that cigarette either goes out or returns to a normal burning phase. So as you can see, with having these cigarettes and these oxygen sources close to our face, we wanted to get a high amount of injury or high severity injuries because of that rapid burning. Oxygen also, when you're
But we had someone freaking blow up an ER in Atlanta.
They lit a cigarette.
It was cigarette.
It was pretty funny. We didn't like that place anyway.
Yeah.
It was Southern Regional. Trash. They
They
decapitated
shut
the
down an
baby.
ER for like 6 months or something. Yeah. All right. So be mindful. This is my soapbox. Ding, ding. I'm gonna get on it. So oxygen toxicity is the air sac collapse and there's an overload of oxygen. The premature infants, the wee babes, we try to avoid blowing oxygen in their eyes. That's true. We don't want to cause. He knows. I get on this soapbox, and then every time someone wants,
Look, I told you, Lincoln almost got taken out.
I knew it was coming.
She should have served it.
Yeah. So if I should have.
You should have.
So if somebody has, is there no? Oh, wonderful. Good death. So if someone is having like a heart attack or a stroke or myocardial infarction, we try to keep their oxygen above 94. So we want it 95 to 99 because that oxygen at a tissue level can cause a lot of damage if you have a lot of oxygen in their system. So if someone's having a heart attack and they're satting at 96%, let them be. As soon as that oxygen drops below 95, put them on like a nasal cannula. Either whatever you feel is necessary at the time. All right, this is the one that really gets me. It makes me so mad. So respiratory depression or respiratory arrest when hypoxic drive is depressed in COPD patients.
Hold on.
Makes me so mad. So
They used to teach this.
they
'Cause I was
still
taught
teach
this.
it. It's still in y'all's book. So this is the thing that really irritates me. Oh, you can go ahead.
No, I was just saying, they hammered this in my head. So when I was a firefighter, we'd go out to these freaking COPD patients, they'd be like at 88%. I'd be like, no, can't give you no oxygen. They'd be like, yeah. I'd be like, no oxygen for you.
Yeah.
And I thought I was doing the right thing. No, absolutely not. No.
So, hypoxic drive in a nutshell. We have those little receptors in our like vasculature, our aorta, our carotid bodies, medulla. Whenever our oxygen goes low and our CO2 goes up, it says breathe. Well, the majority of that is driven on oxygen. So when that oxygen goes low, it says we need to breathe now. We need to get oxygen. Well, somebody that has COPD, their theory is that if somebody has been breathing on low oxygen for so long because they have chronic COPD, their body no longer gets triggered because of low oxygen, but instead it gets triggered because of high CO, carbon dioxide. So their theory is if you give these patients oxygen, their CO stays down, their oxygen comes back up, and nothing is triggering their brain to breathe. So your COPD patients are going to go hypoxic and stop breathing because you give them oxygen. Well, then EMS seen this and they ran with it. And they're like, COPD patients, they don't get oxygen. Freaking PAs, I've had a PA tell me with a lady satting at 78% that he wasn't going to put her on oxygen because she had COPD. Cue my quote from this study. There was a study done in 1949 that they had one patient that went hypoxic because they were giving him oxygen. They don't even know if it was caused by them giving him oxygen. But they were like, you know what? This makes sense. So we just are going to withhold oxygen, right? So then there's another study. Here we go, right there. So this study came out where they re-looked at this article from 1949, and they were like, maybe there's something to this. This was done in 2012, and EMS is still practicing, don't give the oxygen to COPD patients. But this study came out, and I quote, this misconception has resulted in the reluctance of clinicians and nurses to administer oxygen to hypoxemic patients with COPD. In most cases, this is an unwise decision, putting at risk the safety of patients with acute exacerbation of COPD. Please do not withhold oxygen from your patients. If anyone ever walks up to you and says, well, they have COPD, so why do you put oxygen? You take this elbow right here. No, just kidding. You thank them for their service, and then you leave and put them on oxygen. I think. So that's my soapbox. It gets me riled up.
Then I call you a ding ding.
Yeah, it makes my ears hot, and then everyone around the station knows
So-
it does. So they're always like, hypoxia, try.
Well, theoretically, the only time this is going to affect a patient is when they're sitting on a ventilator for long periods of time. That's why it's hard to pull patients off ventilators after they've been on them, because these patients, their bodies, if the vent is not appropriately set up and they're not appropriately weaned off, like I said before, their bodies are so used to being hypoxic that when they get put on a ventilator and their body gets a little taste of what oxygen is like, when they go to come off the ventilator, their body doesn't like it, and they're like, frick you, we're out, right? So that's where that comes into play. It doesn't matter in the 30 minutes to an hour that you're going to be dealing with these patients. It matters to the ICU people down in Reno or Salt Lake that are putting these people on ventilators for a month and then trying to take them off. So don't be afraid to give them oxygen. It's not going to kill them. Don't worry. If they die while you put them on oxygen, it wasn't your fault. It's something else happened. So.
Okay. Ears are cooled off now. Can you? All right, so humidifiers, we don't really carry these on our ambulance. You might see them if you're doing like interfacility transport or like long-term care stuff. They'll put oxygen, they'll run it through a humidifier. That oxygen can dry out the nose and it causes nosebleeds. So they'll just put them on a little bit of hydration.
Humidified
Yeah.
oxygen.
Don't go opening this thing, looking in there. If you see a glove with something floating around, change it out. They're breathing this in. So try to avoid infections, right? So 3 major issues with supplemental oxygen. It is a drug. It is on your drug cards. It's in your medication. It's a drug that we can give. So it is possible to get too much or too little of it. That's where it comes in, where we keep our SpO2 from 95 to 99%. And then if you withhold oxygen, obviously the COPD thing, perfect example. You can give not enough of it. It can cause harm, so those heart attack and stroke patients, don't go blasting them in the face with oxygen if their SpO2 is 5. You don't want to cause more harm. And then it's based on your evaluation. So we can look at SpO2. Some people live at an SpO2 of like 91%. Those COPDers, they're on like maybe 1, maybe 2 liters of oxygen. They say, yeah, I live at 92. Don't go freaking out because they live at 92. But if you have somebody that's struggling to breathe and they're at 92, those are 2 different patients, right? So we are treating our patient and not our monitor, right? So if you walk in, the patient's blue and they look like crap and they can't breathe, give them oxygen. Okay? And then always ventilate apneic patients. I have seen providers bring in cardiac arrest into the hospital and they have a nasal cannula going. They're sitting there pumping on their chest and there's nobody else doing any kind of other oxygen things. So ventilate your patients. If you have a BBM, ventilate your patients. All right, so mild distress, yes. Yes, sorry. I got excited. Y'all got me talking about hypoxic drive. Mostly Billy, because he held up his sign.
She grabbed the page out. You could have run.
Yeah, you don't know what's
I
going.
like it better.
You don't know what's coming.
Well, next time, just step over here. I mean,
I
they're
was
still
trying
in
to throw
play.
it soft.
Huh?
I was trying to throw it soft.
It might hit him with a wall
It's
first.
okay.
So it'll only ricochet a little. Problem.
Yeah. Our
She
dog,
throws like a girl.
our dog has a little piggy that blinks. We called her Oinker. And I threw it at him one day and it bounced off his knee and smacked him right in the face. He's caught it a couple times.
Did you pretend cry?
Huh?
You pretend cry?
That's what I want to hear. Billy was in class last year. Billy saw me coming here with a freaking swollen lip after she gave me the people's elbow.
Whatever, that was your fault. All right.
I was
You
asleep.
walked into
I'm trying to sleep. You walked into my elbow.
You walked into the elbow.
That's her story. She's sitting there.
All right, so I will say, the National Registry, their test in all of their glory, loves to put anybody that's in any kind of distress on a non-rebreather at 12 to 15 liters per minute, right? In real life scenarios, we don't use this thing all that often. I will usually, like if someone's pretty low, but they're like breathing and it's not like super, super bad, I put them on a nasal cannula either. The National Registry would be like, put them on a non-rebreather.
Chances are if they bought a non-rebreather, they bought some other form of oxygen consumption, whether that's a CPAP or a nebulizer or whatever. Like it's rare that somebody just needs a non-rebreather.
Could you trade out nasal pen up to patients come through? If they're like, stripping the nasal pen off, so they like it, you just put it in on them, or?
I've had a lot of patients that do rip out the nasal cannula. We don't like how it tickles their nose.
My grandma.
So.
Yeah.
Yeah, you can try like sometimes you can put it in your mouth. That kind of helps. If it's like really bad, they don't want anywhere near their face. I'll put this on and just have them hold it close to their face. But
Kiddos are the freaking worst.
yeah,
Anything you put near their face, they're like, yeah, you're.
breathe it.
Yeah, to your side.
So here's our devices. This chart should be in your guys' medication list paper. The ones that are highlighted are the ones that we use most commonly pre-hospitally. We do use trache masks if we have them, but you can put a little baby non-rebreather over there. Partial rebreathers, they look like this a little bit, but without all this extra stuff over here. They have more holes in them, so you can see like these little holes. So they got more holes in them. The non-rebreather, there's your non-rebreather. BBM, you guys have all seen, put your hands on, and then the nasal cannula we passed around a little bit ago. Kids, like Chaz was saying, they hate it. They are like, get it away from my face. If you can have mom kind of hold it close to their face, like a non-rebreather, that's really good. That's an efficient way of getting oxygen for a kiddo if they're just not having it.
A lot of times you can take those nasal cannulas and just snip the end off of it and try to like tape it on their face.
Yeah.
You can do stuff like that just to kind of get blow by. You can take the non-rebreathers and like sit on their chest. Different things. You kind of come up with some techniques. I was sitting over there playing Kung Fu Panda with a kid all the way down to Winnemucca a couple of weeks ago with oxygen. So you come up with all kinds of creative ways. Ended up blowing him a freaking glove balloon and like just gave it to him and then just like held the oxygen in front of his face. And he was like playing with the balloon. So just come up with ways to do it.
I don't think this is actually an oxygen thing, but it looks like it. All right, special consideration. Are you gonna put CPAP or BBM somebody that's like this? Probably not. Good luck getting it sealed. What's our difference if someone's choking? We do abdominal thrust. Now we do the back blows.
That's what was first.
Yes, yes, very good, very good. But every time you bag somebody that went unconscious from choking, you're gonna look in their mouth. Don't do a blind finger sweep, but you're gonna look, bag. If you see something, pull it out. I put peanut butter up here for anaphylaxis. It kind of has a twofer, so yeah, anaphylaxis. Obviously, that's gonna be hard to ventilate somebody that has a lot of swelling in their airway. Chaz and I was going through paramedic school. I went through the airway portion. I learned how to deal with nasty airways. I said, we hopped on the truck for our next shift, and I said, I really want a nasty airway because I just went over airway stuff. And he's like, God dang it, now we're going to do this. So you call that to a fall. It updates in the notes that it's unresponsive, choking, updates in the notes that it's a cardiac arrest. And we walk in, and this lady, it looks like she took a
And I
bolt.
called this one the whole way. Every time they would send an update, I'd be like, this is about to turn into this. It would update. This is about to turn into this.
Well, it came out as a fall, and he's like, imagine if they choked on a peanut butter and jelly, and then it updated as a choking. He's like, and it was like CPR in progress, peanut butter in the airway. And he's like, see, like we spoke everything into existence. It was wild. It looked like she took a bowl of peanut butter and just like went, like inhaled it all. Her whole mouth was just filled with peanut butter, everything. Suctioning peanut butter, that's not a thing that's possible. Like it's so viscous, it's so thick. So I was like, I shoved the eye gel in her. I pour like saline flushes, kind of mix it around and try and suction through it. Rough. We were still trying to ventilate, but it wasn't happening.
Becca didn't eat peanut butter for a couple of months after that.
Yeah, it sucks because like my lunches for the last like 3.5 months had all been peanut butter and jellies, and I was not able to eat that for a while.
The inside of our suction canister looked like a peanut butter milkshake.
It was so bad. And then kiddos, obviously, they're anatomically they're different, right? So we want to make sure we put them in a sniffing position. We don't overextend their neck. We only give a breath up until their chest fills. So, if you guys, this is in your book. So, whenever you guys are assisting with a advanced airway device, eye gel is easy. All they do is shove it in there, then you back and tell us if it works or not. But if you're assisting with an innovation, I always suggest if you're working with a paramedic to run through this procedure. And so you get used to what to grab, what not to grab, how to help, how to assist. Like you guys saw whenever Chaz was looking at the vocal cords, Calvin was standing behind him and said, I see vocal cords, because Calvin has practiced with us a lot on how to, do this. This is something that we always pre-oxygenate. So if our patient, this is something y'all can help with. So we put a nasal cannula, a regular nasal cannula, and then a non-rebreather. We try to get as much oxygen in them as we can, or if, they're not breathing and you need to bag them, we'll do nasal cannula, turn it all the way up to 25, and we'll bag them over the nasal cannula. So pre-oxygenation is huge. If you can assist putting them in a sniffing position, that's really helpful. Shove some blankets or whatever behind their shoulders, help them get in that ramped position. So whenever we do go to innovate, we want to set ourselves up for success. That burp maneuver you were talking about, it's just a little bit of pressure. And in reality, we shouldn't be having you just like push on their trachea. I would never tell you like, just do the burp maneuver. I'm going to push it first until I see what I need to see, or I'm going to have somebody, because you can cause a lot of trauma by like just shoving their trachea back. So I'm going to do it first, and then I'll say like, hey, hold where this is. So then you just hold it where it was. But just so you know, they call it burp. They call it a Selleck's maneuver. That's another name for it.
Correct pressure.
Correct pressure. It's got a bunch of numbers. And then this is what we're looking at. So you guys seen this the other day? The vocal cords, the little epiglottis. See all that. Once it's placed, anytime that patient gets moved, and initially when we place it, we always listen to lung sounds and epigastric sounds. So the order of which you listen, that tube is passed, we say the tube's in, and we give breaths. You listen to the belly first. If you hear blub, 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 that's a bad day. If you bag and that tube's in the wrong hole, you're going to hear it in the belly. That's what's going to kill them first. So we listen to the belly first. So belly, left lung. I'm like, who's left? My left. We listen to the belly, then the left lung. Because if we put the tube in too deep, it's going to go into the right lung first. So we're going by order of what's going to kill them first. So in the belly, left lung, we want to hear breath sounds, and then right lung, hear breath sounds. So if I right main stem a patient because I got excited and shoved that tube in too far, they're only going to have lung sounds on their right because that tube's all the way down into just their right lung. So anytime the patient's moved and initially passing, we always double check lung place or lung sounds and epigastric sounds. We also secure it. Whenever we secure it, there's numbers on the tube. So we'll say, okay, it's 21 at the teeth, and we'll secure it. Well, anytime that patient gets moved, we always check, okay, it's still 21 at the teeth. And if that changes at any point, we always double check. So this is big, because if they don't have that tube in, they don't no longer have an airway. So that's our main thing, right? Okay. Where's my thing? I know I told Lakin's name, but I don't know what I did.
Oh, I got it over here.
Okay, Lakin, you were next.
Okay.
Upon arrival to a difficulty breathing scene, you find an adult female patient who is semi-conscious. Her respiratory rate is 7. She appears pale and slightly blue around her lips. Is this patient in respiratory distress, respiratory failure, or respiratory arrest?
Respiratory distress. No.
Look at her respiratory rate.
Okay, failure.
Failure, yep. She is failure. Why is she blue around her lips?
Because she's lacking oxygen.
Good. And what are you going to do for her?
Give her oxygen.
How?
Probably nasal cannula.
So whenever somebody's respiratory rate is not sustaining, normal is 12 to 20. Hers is less than 8. So you want to back her.
Okay.
CBM, back her. So less than 8, you back her. Matthew? Matt? Ian?
That's awesome.
One of the Austin people.
Oh, okay, no, I was trying to, this is like,
Yeah. Steven.
Steven.
Very good. Very good.
Very good, very good. You're dispatched to a residence for a difficulty breathing call. On arrival, you find a female in her 60s. She's in a tripod position. She's breathing at a rate of 32. She's coughing up frothy sputum that looks like this. You see intercostal retractions, and her SpO2 is 85% on room air. She is able to follow commands and appears very anxious. Is she in respiratory distress, failure, or arrest?
Distress.
Good. She's able to follow commands. So she was altered. That puts her in what? Arrest or distress.
Failure.
Failure. Thank you. It was coming. It was coming. All right. What are you going to do for her?
Give her from like the stuff coming out of her mouth, you said?
Yep, this frothy stuff. She's like, and it's like coming out.
Nasal cannula? No?
So her respiratory rate is higher than what? Higher than 25. She's got intercostal muscle use. Her SpO2 is less than 94. She's not puking. She's coughing up lung fluid. So this would qualify for CPAP.
This is actually like textbook CPAP stuff. This is what you're going to see with like your congestive heart failure patients a lot. This is what you're going to see. This is like a 2 or 3 time a weekend occurrence for us in Atlanta because everybody out there had congestive heart failure because you like fried Twinkies. So this is like your textbook CPAP patient.
You don't have to worry about like the frothy stuff or whatever.
You're actually trying to push that out of their lungs.
Or back into their lungs.
Yeah. So try to get it, go down there in the little capillaries and redistribute into their system.
Okay, so like,
Yeah, and you actually mix that as you kind of progress through your training. You mix that with like nitro to try to help open up their vasculature. So if they have nitro, that's a good time to, hey, you got nitro? Let me help you take this real quick. Put them on CPAP because you vasodilate them, right? Because nitro is a vasodilator. You vasodilate them. It gives a bigger surface area around those capillaries so that they can come in and try to push that fluid out.
they have to have that on them, right? I just have to use it on them.
Yeah, it has to be their nitro.
They keep that available carry in the ambulance.
You can as an advanced EMT, you can as an EMT. Like we have nitro tablets and we also have liquid nitro. So
Yeah, so anytime you hear like pink frothy or just frothy sputum, that is telling you that they have fluid buildup in their lungs and it's now coming out of their mouth. And that is a bad day. little bubble treatment, whenever you see that. And the best treatment for it, if they're able to follow command and do all the things, put them on CPAP. They need positive pressure to push that fluid out of their alveoli. So their alveoli is full of this same stuff. But you're just physically seeing it, but their alveoli is also full of it.
So you don't suction that out, you just throw right onto the machine? and try to
If
push it
there's
back
like
in?
a whole
There's a,
bunch,
yeah.
suction it. But
Typically, if there's a whole bunch, just have them.
Can I interrupt you guys? We have a question.
yeah,
So we're not allowed to do
you're cutting out really bad.
EMTs in the state of Nevada can do CPAP. We looked this up last year. EMTs in the state of Nevada can do CPAP, and we have guidelines here, so you're able to do CPAP in Lander County, if that makes sense.
So that is actually.
Yeah, what?
You can type in the chat, Tina, because you're cutting out really bad.
Yes, CPAP is within our scope here. We can do CPAP here. Now, that's not saying you can do it everywhere. You can do CPAP as an EMT here.
And it's in your scope of practice per the National Registry. So chances are you might get a question on your NREMT about CPAP because it's in your scope of practice. So anytime something's like generally in your scope of practice, you're gonna get questioned on it when it comes to NREMT. So anything in that textbook, you can get questioned on. Whereas like you might go somewhere and they're like, yeah, EMTs can't do CPAP. You're still gonna be tested on it at some point or another because it's your scope. But you always have to follow your local protocols, if that makes sense. So like in Atlanta, and maybe it might be this way here, we just haven't looked into it. Like you guys can only assist with the EpiPen. In Atlanta, if the Epi was already pulled up into a syringe, the EMT could administer it. They didn't have to have the patient's EpiPen to do that. So I think they talk about that a little bit in the book too. Some places it's in your scope as long as it's pulled up.
Yeah, I'm talking to him.
Oh, okay.
I'm clarifying.
Okay. Perfect. All right, Shia, you're next. So you're dispatched to a 28-year-old female with difficulty breathing. Her husband meets you at the driveway and shows you this and I want y'all to pay attention, right?
It's like a flying monkey or what?
Let's grow. Gotcha.
He's just standing there.
He's so confused.
Okay.
You just like grab the pizza out.
Here's your pizza.
Thank you.
You walk inside to find a young female in the fetal position on the couch. She's breathing at a rate of 28 breaths per minute and her skin appears flushed. She is able to communicate that she is scared of squirrels and there was one in her house. How do you treat this patient? So she in respiratory distress, failure, or arrest?
I say at most she's in distress.
Good, good. She's able to talk to you. She's scared, right? And what are you gonna do? She's freaking out. She's breathing fast. 28 is too fast, right? 28 is normal, so she's a 28.
I mean, it sounds like she's got oxygen. She's flush, right?
Yeah, she's flushed.
So she's got good oxygen, but.
Okay.
And we're only talking air, just. I mean,
Yeah, she's just chatting with you. She's freaked out.
I'm not touching it.
Okay, I don't know. Okay, does anyone want to help? Okay, you could, sometimes that helps, like if you put somebody on nasal cannula, maybe to just kind of ease their psyche, but she doesn't need a nasal cannula, right?
We're back and tell her how.
Huh? Yes, exactly. Good. Yeah, so therapeutic communication, right? So talk to your patient. Yeah, you're like, you need to go get checked out for rabies. And then it bites you. Yeah, no, that's perfect. That's what I was looking for. So sometimes our patients are just anxious, right? So we always want to check everything. But you've seen the video, you know, it's girl running her house, she's clearly freaking out. So sometimes it's like, okay, take some deep breaths, talk them down. Like therapeutic communication is huge for a lot of patients. You'll see this with like abuse, like domestic abuse. She'll show up and sometimes like somebody's really upset. Not just females, males are the same. 20-year-old males also love to be anxious and cry for their mommies. I've noticed. So therapeutic communication. That's what I was looking for. Very good. All right. What questions do y'all have? No questions. I only kept you a couple minutes. 5 minutes. Very good. Very good. Awesome. So chapters 10, 9 and 10. What's the next? Chapters 9 and 10 test Thursday.
A lot. Don't worry about it.
Don't worry about it. Worry about your.
You walked on this light and one earlier.
I've got tactical golf club deployment.
Yeah, we got freaking, you know, how people have like bathroom guns, and laundry room guns, and bedroom guns. Yeah,
It's called golf.
he's got golf clubs over there. You might not get shot right